Bismillahirrahmanirrahim. I would like to introduce myself initially. There, I'm Dr. Adi Karim. I am grateful for today, for tonight, to introduce or to be moderator of this interesting webinar. I welcome everyone, particularly our mentor, our colleagues, and warmest welcome for our distinguished speaker. We talk about this night about the comorbidities in epilepsies. As you know, the burden of comorbidities in people with epilepsy is high. Several diseases of epilepsy like ADHD, depression, anxiety, dementia, migraine, heart disease, even peptic ulcer, and extra. This is more common than general population. Several mechanisms explain that maybe is direct or associated with the shared risk factor or bidirectional relationship. So these subjects and these comorbidities and others, we have a distinguished speaker, actually, the Dr. Charles Hammond, MBSHB pediatric neurologist, MB HIL FW ACV FGCP consultant pediatric neurology, Confo Inoki Teaching Hospital, Senior Lecturer, Department of Child Health, School of Medicine and Dentistry, Guam, Nkrumah, University of Science and Technology, Commercial, Ghana. Thank you, Mr. Hamoud, for joining us. Mr. Hamoud, the floor is yours, please.
Hello, everyone, and good evening, wherever you are. My name is Charles Hammond, and I'm speaking from Ghana, and this evening I'll be talking to us on the comorbidities of epilepsy in children. So the objectives of this lecture will be to describe the range of cognitive, psychiatric, and medical.
Sorry, we're having a technical issue. Just one moment.
Hello, everyone, and good evening, wherever you are. My name is Charles Hammond, and I'm speaking from Ghana, and this evening I'll be talking to us on the comorbidities of epilepsy in children. So the objectives of this lecture will be to describe the range of cognitive, psychiatric, and medical comorbidities in epilepsy, to identify the different models and types of associations between epilepsy and its comorbidities, and to outline the specific comorbidities in children with epilepsy. So epilepsy is a common neurological disorder affecting over 50 million people worldwide, and the majority of affected persons live in developing regions, mainly in Africa, Southeast Asia, and Latin America, and other parts of Asia. The comorbidities in epilepsy refer to conditions with greater frequency in persons living with epilepsy than found in the general population. Comorbid conditions in epilepsy are found across the lifespan, from infancy through childhood, through adolescence, into adulthood, and then even into the elderly. So epilepsy comorbidities may be the cause of the epilepsy, may be caused by the epilepsy itself, or may be due to a shared neurobiological links between epilepsy and other medical conditions, or it may be as a result of long-term treatment with anti-seizure medications, and they include cognitive, psychiatric, and medical comorbidities, and then even physical comorbidities. these comorbidities occur either alone with epilepsy or in various combinations. We want to look at some epidemiological data on some of the psychiatric and cognitive comorbidities of epilepsy, especially in children. So the reported rate of psychiatric comorbidities in epilepsy is between 6 to 64%, compared with 7 to 26% in non-epilepsy controls. This is according to a study in 2009. Again, there is a higher incidence of coexisting cognitive impairment in persons with epilepsy compared with non-epilepsy controls. And the common psychiatric and cognitive comorbidities in children with epilepsy include depression, anxiety, autism spectrum disorder, attention deficit and hyperactivity disorder, learning disabilities, and mental retardation or intellectual disabilities. To talk about the medical comorbidities in persons with epilepsy, it is reported that between 26 and 84% of persons living with epilepsy have at least one medical comorbidity. And the common medical comorbidities in children include headaches, physical injuries such as burns, fractures, sometimes even drowning, infections, and neoplasias. Next, we want to look at the causal models for epilepsy and its comorbidities. So there are various models to explain the associations between epilepsy and its comorbidities. One is that the epilepsy or its treatment causes the comorbid condition. And we'll look at these into detail as we go on. The second model is that the comorbid condition or its treatment causes the epilepsy. That is the reverse of the first one. And the third is that there is an underlying neurobiological or environmental factor that is causing both the epilepsy and its comorbidity. And the fourth one is that there is a completely independent cause of the epilepsy and the comorbidity, so they don't overlap. And the fifth one, which is what really happens in reality, is that there is a complex association involving all the four that I have previously mentioned. So there is a complex association, and that is what usually happens in real life situations. So I will start by looking at the first model, and then we'll give a few examples as we go on. So the first model says that epilepsy causes the comorbidity. So if you have a poorly controlled epilepsy, then the child may present with status epilepticus, for example, leading to brain injury and then subsequently developing cognitive impairment. The other way around it, if you are looking at the treatment with anti-seizure medication, is that you have epilepsy, you put the patient on anti-seizure medication, and the anti-seizure medication causes the cognitive impairment. So this is the situation where the epilepsy leads, or its treatment leads to the comorbid condition. The second model is where you have the comorbid condition leading to the epilepsy. For example, you have a structural malformation, and that structural malformation causes the patient to have epileptic seizures. Then in that case, it is the comorbid condition that is leading to the epilepsy. So it will predate the epilepsy, or it will come before the patient starts to have seizures. The third model is when you have an underlying etiologic factor causing both the epilepsy and the comorbid condition. And here, for example, you may have HIV infection. We know HIV is very neurotropic. It enters the brain, and then it can cause epilepsy. And the same HIV independently can also cause cognitive impairment. So here you have one etiologic factor causing the epilepsy and the comorbidity. The comorbidity being the cognitive impairment. The other example is tuberous sclerosis can cause epilepsy, and it can also cause autism spectrum disorder. So one underlying factor causing both the epilepsy and the comorbidity. The fourth model is where you have completely independent causes for both the epilepsy and the comorbid condition. So you have one disorder causing the epilepsy. It could be a genetic disorder causing the epilepsy. And then you have a completely different condition causing the comorbid condition. So you may have someone having epilepsy from, let's say, structural abnormality or structural malformation, and then having cognitive impairment from genetic causes or chromosomal causes like trisomy 21. So in this case, the two probably do not overlap. But in reality, what you have is a very complex association involving all the four combinations I've previously talked about. So you have a disorder that can directly cause cognitive impairment and also may cause epileptic seizures. The epileptic seizures lead to brain injury and worsens the cognitive impairment. At the same time, because of the epileptic seizures, the patient is put on anti-seizure medications, and some of these anti-seizure medications will then go on to cause cognitive impairment. And so that is more complex, and that is what is likely to happen in most patients in reality. Now we would want to look at a few some common comorbid conditions in children with epilepsy. So I want to highlight this table from the study that I earlier on cited, and they did a very good job by classifying the comorbid conditions into psychiatric, cognitive, and medical comorbid conditions. And I would highlight a few of them because they are of importance to pediatricians and pediatric neurologists. And these include depression, anxiety, autism spectrum disorder, and then under the cognitive comorbidities, you want to talk about attention deficit hyperactivity disorder and learning disability, mental retardation. The medical comorbidities are many, but I'd want to talk about cerebrovascular accident, migraine, weight abnormalities, fractures, and so forth. So first, we would want to look at epilepsy and learning difficulties. So children with epilepsy have a high rate of learning and intellectual difficulties compared with sibling controls. And this is from a study done in 2000, where they compared children with epilepsy and their non-epilepsy siblings. And it was noted that these children with epilepsies had high rates of learning and intellectual difficulties compared with their siblings. Majority of them, or a lot of them, let me say 30 to 40% of children with epilepsy will have an IQ score of less than 70, making intellectual disability the most common comorbid condition in epilepsy. Cognitive outcomes differ among children with various epilepsy syndromes, and the worst outcomes are seen in children who suffer infantile spasms or epileptic spasms, or West syndrome, Dravet syndrome, Lennox-Gastaut syndrome. So these three categories of patients with epilepsies will have the worst cognitive outcomes. It's also important to note that temporal lobe epilepsy will lead to poorer memory function than frontal lobe epilepsy and childhood absence seizures. So these ones have to do with where the abnormal neuronal networks are, the focus of the abnormal neuronal networks within the brain. There are many factors that contribute to learning and intellectual difficulties in children with epilepsy, And you are more likely to suffer intellectual difficulties if you have your seizure onset at a younger age, if there is a symptomatic cause, if you suffer epileptic encephalopathy, if you have an abnormal EEG as against a normal EEG, and then if you have been put on prolonged anti-seizure medications, especially medications like phenobarbital and also topiramate. Next, we want to look at epilepsy and language impairments. So speech disorder is reported in about 27.5% of children with epilepsy, and they include lower scores in word knowledge, category fluency, response to commands of category fluency, and then response to commands of varying length or increasing length and complexity. And this is from a study done in Taiwan in 2015. Language impairment in epilepsy may arise from several factors, including the underlying neuropathology, the impact of the seizure on the developing brain, the development of cognition, the severity of the epilepsy, and then anti-seizure treatment with anti-seizure medications. And especially topiramate has been reported to interfere with language development in children. Again, language impairment is associated with some epileptic syndromes, such as Landau-Kleffner syndrome, and then the epilepsy with continuous spike and slow wave during slow wave sleep, or what we call the CSWS. But then, again, it's interesting to note that even in some form of so-called benign seizures, like the self-limiting epilepsy with central temporal spikes, there are some reports of mild language impairment in some of these children. That makes us sometimes to think that it is a whole spectrum, and that Landau-Kleffner syndrome and self-limiting epilepsy with central temporal spikes, previously benign Rolandic epilepsy, are probably on the same spectrum, with one being on the milder end of the spectrum and then the other being at the severe end of the spectrum. Next, I want to talk about epilepsy and attention deficit hyperactivity disorder, or ADHD. So, and I want to talk about this paper published way back in 1955, almost 70 years ago, in the Lancet, which described the hyperkinetic syndrome in children with epilepsy. And in this paper, the description given by the author is that these children had overactivity, distractibility, poor impulse control, and behavioral problems. This is not so different from what we know today as ADHD. So ADHD has been around for a long time, and it has been associated with epilepsy way back in the 1950s. The presence of ADHD is estimated to be between 12 to 39% in children with epilepsy, compared with 3 to 7% in the general population. And many factors account for the co-occurrence of epilepsy and ADHD, and common underlying etiologies will include perinatal insults, head injuries, metabolic and genetic factors, and then the effect of anti-seizure medications. Also, metabolic abnormalities involving lipid metabolism and neurotransmitter metabolism, especially those involving noradrenaline and dopamine, are possible underlying factors. The symptoms of ADHD are more common in some specific types of epilepsies, especially in frontal lobe epilepsy, in childhood absence epilepsy. That's probably because there is inattention, a lot of inattention in childhood absence epilepsy. And then again, in the self-limiting epilepsy with central temporal spikes. ADHD frequently in children, it frequently predates seizure onsets, which is to suggest that the seizure itself may not be the underlying factor for the development of ADHD, because some children with ADHD and seizures often have the ADHD manifesting before the seizure onset. So the presence of comorbid ADHD and epilepsy is usually associated with poorer performance in tasks of executive functioning, and that is very understandable. You need a lot of concentration to perform some executive functions. The next I would want to highlight is autism spectrum disorder in children with epilepsy. It's probably one of the most studied topic, or most reported on in the literature. And I want to highlight this paper, which looks at epilepsy and autism spectrum disorder as two sides of the same coin. And in this paper, the highlights are that comorbidity of epilepsy and autism is frequent, and that between 6 to 27% of children with ASD or autism also have epilepsy. And children with epilepsy, in children with epilepsy, the rate of ASD or positive screen for ASD symptoms range from 5 to 37%. That is quite high. The mechanisms for the coexistence of epilepsy and ASD are complex and probably include underlying encephalopathy, which is driving both conditions, or abnormal neuronal connectivity, genetic mutations, environmental factors, sometimes catastrophic childhood epileptic syndromes, and then early age of seizure onset have all been reported to be risk factors for developing ASD in children with epilepsy. So we know that some genetic conditions will lead to disrupted synaptic plasticity and abnormal excitation of neurons, and that could produce epilepsy early in life, and could also produce ASD. But at the same time, the seizures could also lead to ASD. So it's quite a complex association. Some genetic factors and syndromes have been identified to present with both epilepsy and autism spectrum disorder. And they include Fragile X syndrome, the Rett syndrome, tuberous sclerosis complex is probably the most common example we can give, and then some other genetic conditions. Even trisomy 21 has been cited. Metabolic disorders, including disorders of energy metabolism, disorders of amino acid metabolism, mitochondrial dysfunctions could also cause both epilepsy and autism. Environmental factors, which are the ones probably most important to us, because they are the ones we can always work on to prevent the occurrence of these conditions. They will include infections in utero, such as congenital rubella. As a matter of fact, the touches and also HIV infections could also lead to both epilepsy and autism spectrum disorder. And then the use of anti-seizure medicines in pregnancy, especially if a pregnant woman uses valproate. That is also a recipe for developing the two conditions. Bleeding during pregnancy, multiple pregnancy is a risk factor, preeclampsia and eclampsia, and then smoking or alcohol use during pregnancy. Maternal stress has also been reported to result in autism spectrum disorder and also in epilepsy. Preterm delivery is a risk factor for the developing of both epilepsy and autism spectrum disorder because of all the complications associated with preterm delivery, including intraventricular hemorrhage, low birth weight, intrauterine growth retardation, and also hypoxic ischemic encephalopathies, as well as congenital defects, are all risk factors for developing epilepsy and autism spectrum disorder. There are some epilepsy syndromes with high frequency of autism spectrum disorder and other neurodevelopmental disorders. And these syndromes include the West syndrome, Lennox-Gastaut syndrome, Landau-Kleffner syndrome, and then the syndrome of continuous spike and wave, slow wave during slow wave sleep, or CSWS. Next, we'd want to talk about epilepsy and migraine. So migraine has been reported in about 26% of persons living with epilepsy compared to 15% in non-epilepsy controls, meaning that it is actually a comorbidity because it's far in excess of the general population. Comorbidity of epilepsy. Both disorders, both migraine and epilepsy, may have a common genetic susceptibility leading to neuronal hyperexcitability. There is a belief among neurologists that both of them are due to neuronal hyperexcitability. Some of them are channelopathies. Epilepsy and migraine share some common clinical features, and that is very important to note, including aura. Some migraine may present with aura, some epilepsies may present with aura. And then the paroxysmal nature of the events. They come and go, and when in between, the patient is at baseline, or the patient is symptom-free in between, but they come as suddenly, and then they go away suddenly. And that's what we mean by they are paroxysmal in nature. They may both lead to impaired level of consciousness, and they may both lead to focal neurological signs. Also, some medications used for the treatment of seizures are also effective in the management of migraines, possibly by reducing the neuronal instability or hyperexcitability. Another major comorbidity in epilepsy are sleep problems. And in children with epilepsy, there is a significant high number of parasomnias, sleep fragmentation, daytime drowsiness, and bedtime difficulties. And these may be due to the seizures themselves causing the disruptions in sleep, or it may be due to the effect of anti-seizure treatment. Depression, another comorbidity of epilepsy, is more common than other neurological or chronic medical conditions. And the association is again complex. There are multiple risk factors that have been identified in this complex association. One is that the epilepsy will lead to interictal depression. So the patients are depressed because they are probably worried about their seizures, but it could also be because neuronal networks in some certain parts of the brain are driving both the epilepsy and the depression. Then you have psychosocial variables such as stigma, poor self-esteem, rejection by peers, and poor quality of life in patients with epilepsy, which will then lead to depression. Treatment with anti-seizure medications may also lead to mood disorders, including depression, and also lead to sleep disorders, eating disorders, and then some of them may even have suicidal ideation. Especially recent times we talk about treatment with levetiracetam leading to suicidal ideation. Then you may have seizure-related factors which may also lead to depression. In some instances, the depression and other psychiatric symptoms, they predate the onset of the seizures. So this is to say that you can't always blame the seizures for the depression, and that there may be an underlying factor which is driving both conditions. So some biochemical factors have been suggested in this association, and they include decreased concentrations of serotonin, adrenaline, glutamate, and GABA, and then also reduce folate metabolism. These have all been associated with both depression and seizures. If you look at psychiatric disorders in general and their association with epilepsy, it's quite complex. And I came up with this diagram to simplify the association. Sometimes you have a seizure that will lead to mood disorders. And then treatment with anti-seizure medication may lead to mood disorders, may also lead to suicidal ideation. Then you have psychosocial stresses that will lead to mood disorders, and then behavioral problems causing mood disorders and leading to anxiety out of all that. And then sometimes the patient with epilepsy simply have the fear of harm, and that gives them a lot of anxiety. They are worried and they are very anxious about when the next seizure is going to come and what is going to happen to them when they have the seizure. There are other psychiatric comorbidities to talk about, and these include panic disorders. I already talked about suicidal ideations. Some children with epilepsy have had oppositional defiance and tic disorders. There are behavioral side effects of anti-seizure medications that are also worth talking about. Phenobarbital use is known to lead to cognitive impairments. So this is a classical example of where anti-seizure medication gives you a comorbidity. Among the newer anti-seizure medications, topiramate has been reported to significantly be associated with memory and cognitive problems, as well as language problems. They specifically lead to word finding difficulties. Newer medications like oxcarbazepine and lamotrigine probably have a less effect on cognition. So to minimize the effect of anti-seizure medications, it is important that ASMs are carefully selected and then the titration is done slowly. That is why we always advise that you start most of the medications slowly and then increase them slowly as the patient tolerates. And then it is important to use the lowest effective dose. No need to use high doses if the patient will remain seizure-free, or seizures will be controlled on a lower dose. And as much as possible, you will have to avoid polytherapy if possible. But we know that in complex epilepsies, this may not be possible. This table is just showing us the relationship between physical comorbidities and anti-seizure medications in children. And some of these medications like topiramate, valproate, phenobarbital, lamotrigine may lead to decreased bone resorption and cause bone loss. You may also have immunological disturbances with medications like carbamazepine and valproate. And weight problems is common with valproate. Polycystic ovarian syndrome has been mentioned with valproate, and dyslipidemia is also mentioned, not so common, but though mentioned with carbamazepine and phenobarbital. There are other physical comorbidities in epilepsy that are worth noting, and these may include stroke, physical injuries, because a stroke may lead to the epilepsy. Physical injuries like fractures, burns, drowning have been reported in patients who have had epilepsy. Allergic reactions or hypersensitivity reactions, especially with the use of anti-seizure medications. Some of the most feared is, of course, the Stevens-Johnson syndrome, and then many other medical comorbidities that may arise, such as electrolyte imbalance, renal impairment, hepatic impairment. We already talked about bone loss, polycystic ovarian syndrome and weight issues in patients who are using some forms of anti-seizure medications. So in managing the patients with epilepsy and comorbidities, it is important that the management strategy is not focused only on seizure control, but on early diagnosis and treatment of comorbid conditions. This is very important because the comorbid conditions sometimes are even of more worry to the patients than the epilepsy itself. Also, regular screening is very, very important. Regular screening and assessment for possible neurological and psychological comorbidities should be done in both children with newly diagnosed epilepsy and then in those who are on regular follow-up at the clinics. They should all have regular screening for ADHD, screening for autism, for depression, and other comorbidities from time to time. And then a multidisciplinary approach is, of course, very important because you need the neurologist, the developmental pediatrician, the dietitian, speech and language therapist, the family counseling and support is very important. And then supportive educational environments. So we need an appropriate educational strategy and psychosocial support for the child to be properly integrated in. So in conclusion, I want to say that comorbid conditions occur with greater frequency in persons living with epilepsy than found in the general population. And these conditions include cognitive, psychiatric, and medical conditions, and sometimes physical injuries or physical conditions from the use of anti-seizure medications. Again, the causal models to explain the co-occurrence of epilepsy and its comorbidities are quite complex. And specific comorbidities in children include learning difficulties. These are common ones: learning difficulties, attention deficit and hyperactivity disorder, autism spectrum disorder, language impairment, sleep problems, migraine, depression, adverse effects of anti-seizure medications, and physical injuries. And that in the evaluation of the child with epilepsy, it's important to look for these comorbidities and manage them accordingly. These have been my references. And I want to say a very big thank you to the organizers for having me and to all of you for listening. Thank you very much.
Thank you very much. Thank you very much, Dr. Shah Samud, for this comprehensive, fruitful details about comorbidities in epilepsy. So it's the epilepsy is the only part of the problem. It's not the problem. There is a pressing need for new and validated screening instrument and guideline to help with the early detection and treatment comorbid condition. But I have some comment before we go ahead to question and answer. Sometimes just comment. Sometimes the comorbidities give us a clue for diagnosis, such as patient with epilepsy and he has ADHD might be searched about phenylketonuria or creatine metabolism in like in gamma deficiency. So comorbidities with epilepsy, you have to be think for other diagnosis, particularly if it's again earlier before the treatment. Now we go to question and answer. So Mr. Dr. Khaled Richard Bright asked about, thank you so much for presentation, very educated and expected. Which anti-seizure is the question, which anti-seizure medicines is or are particularly associated with ADH, and how long after use will be suggest screening be carried out?
Okay, so thank you very much for that question. The first one, let me start by answering the first part of the question, which says that which anti-seizure medication is associated with ADHD. So there is no direct association between any of the anti-seizure medications and ADHD. However, we know that medications like phenobarbital may worsen behavior in patients who already have an underlying behavioral disorder. So the phenobarbital is a very useful drug, very, very useful in neonatal seizures, in status epilepticus, and in some resource-poor regions like ours, we may even use them in long-term seizure management. However, you have to be careful if you are using them in a child with a very disruptive behavior, because they might worsen the behavior. Sometimes even levetiracetam has also been cited to worsen behavior in some children. So these are a few examples of medications that I can say may worsen behavior, but they do not in themselves cause attention deficit and hyperactivity disorder. The second part of the question, which says that how long do you need to put this child on medication before you screen for the comorbidities? The answer is that you start screening as soon as you see the child. So even at presentation, when the child first presents, it is important to look for comorbidities. Remember, we said that some of the comorbidities may predate the epilepsy. They may be there before epilepsy. In many children with autism spectrum disorder and epilepsy, the autism spectrum disorder predates the epilepsy. So it's important to screen for the comorbidities right away. And Dr. Karim just mentioned that the comorbidities may even be a clue to the epilepsy diagnosis. If you have a child presenting to the epilepsy clinic with loss of language, a child who previously had language development but is losing the language after onset of epilepsy, then you begin to think of the Landau-Kleffner syndrome, for example. So it is important to screen for comorbidities as part of the initial workup for the epilepsies. And then also, once treatment is started, from time to time, maybe I would say at every 6-month interval or so, you may have to do some form of screening. It may not be a complete screening, but you may have to do some sort of screening to look for the comorbidities. And then also, when you know the underlying cause of the epilepsy, then your index of suspicion for some of the comorbidities should be lower, should have a very low index of suspicion. If you have a child with a tuberous sclerosis presenting to you with epileptic spasms, for example, as you go on, as you keep following up this child, you have to be looking for signs of autism spectrum disorder, because we know that they are very closely linked. So I will not prescribe any specific timelines for screening children with epilepsy for comorbidities. It has to be individualized, and it will depend a lot on what they are presenting with, what the underlying cause is, and what treatment we are using. I think I've answered that question. Thank you.
Thank you. That's great. We have other questions from Livia Reynald, which is best medication. He asked about which is best medication for psychosis, particularly in DEE, developmental epileptic encephalopathy. Is there any medicines you prefer for this treatment for epileptic patient?
So in developmental epileptic encephalopathy, so in DEE, you have to evaluate the child again individually and then establish the underlying causes. And that would inform you on the choice of anti-seizure medication. I don't know if the person is asking about the best treatment for the psychosis or the best treatment for the epilepsy. So the best treatment for the epilepsy would depend a lot on the seizure type or the type of epilepsies the child is presenting with. If it's a syndrome, you've been able to categorize it into an epilepsy syndrome, the type of syndrome you are dealing with. Then the treatment of the psychosis, I will usually involve a child and adolescent psychiatrist. That is where I mentioned that a multidisciplinary team approach is very important. So I would always involve a child and adolescent psychiatrist to help in the management of some of these psychiatric comorbidities.
The next question from our Prof. Dr. Ghad Jindil is said, thank you for your informative lecture. He said there are other anti-seizure medicines apart from topiramate, like phenobarb, zonisamide, and even valproate, which of them are more harmful in your opinion? His comment, and he want, as I understand from his question, your opinion about these medicines, about phenobarb, zonisamide, valproate, which one more harmful?
Yeah, so again, it depends on what you are treating, the indication for treatment, and that informs your choice of anti-seizure medication. I will not call one of them as being more harmful than the other. Levetiracetam has been fantastic in the last decade or so for many seizure types, and it's just recently that we are talking about it's causing worsening behavior and suicidal ideations. But we hardly see patients. I have not seen any of my patients come up with suicidal ideation, even though it's reported in the literature. So it is quite an important comorbidity to look for, but it doesn't make the medication that bad. Phenobarbital, as I said, if you live in a resource-constrained area like where I am now, it is a very useful tool for management of seizures in many, many patients. Also for neonatal seizures, we rely a lot on phenobarbital. The surgeons use it a lot before and during and after surgeries, alongside phenytoin. And even though we talk a lot about these side effects, it doesn't make the medications bad in themselves. I appreciate that the questioner added a little bit more, talking about other medications also having behavioral side effects. And I acknowledge that, yes, a lot of them do have behavioral side effects, but I will not be able to say this is better than that or that is better than that. We know that it is more common in the examples I have given, but in some instances, they may be the best choice of anti-seizure medication for the patients.
Actually, next question is about from Dr. Ayman. He said infantile spasm, he mean early infantile epileptic spasm syndrome. The comorbidity start with the epilepsy. Yes, of course, it's because it's encephalopathy. So it's the question about the infantile spasm, how to know when the age below 6 months. I think it's not real comorbidity rather than epileptic encephalopathy. What's your opinion, Dr. Charles, about early infantile epileptic spasm syndrome?
Sorry, I didn't get the question clearly, but
the question is associated. He said there is associated. I think he mean comorbidities with the onset of epilepsy in the patient with the early infantile epileptic spasm. Before 6 months, how to know there is comorbidity? I tried to ask the question, but I need your opinion also, because I think this is not real comorbidity. It's epileptic encephalopathy as the epilepsy is encephalopathy.
Okay, so I think I'm looking it up now in the chat box, and the person is asking if infantile spasms are associated with onset of epilepsy in pediatric patients. So infantile spasms are a type of seizures on their own. So patients may have different type of seizures, and infantile spasms are a type of seizures on their own, and they are quite disturbing. They usually affect the early brain, mostly in infancy, but it may go on beyond infancy. And they, if not properly treated, they tend to have very poor neurological outcome, and they may evolve into other seizure types, which may be catastrophic. So some seizure types like Lennox-Gastaut syndrome may actually have started as infantile spasms or epileptic spasms. So they are not, you wouldn't say that they indicate the start of epilepsy in children. The start of epilepsy could be other seizure types. Infantile spasms are different on their own.
So next question from Patrick. He said, please, in your line of practice, have you observed any psychotic-like behavior in children or young adults with epilepsy who are being treated with sodium valproate?
Yeah, that's a very good question. Sodium valproate is probably our go-to anti-seizure medication. I think about half of our patients in the clinic probably are on sodium valproate. It is very difficult to say that they develop psychosis due to sodium valproate. We have not seen that. Probably we have not looked so hard for it if it's there, but we have not seen that in our patients. We've seen a number of patients who probably may present with psychosis and epilepsy comorbidities, but you don't want to blame that on the treatment with sodium valproate. So that would probably be my response. The most worrying side effects we have seen from sodium valproate is weight disturbances and boosting appetite. And because it boosts appetite and you also tend to have fluid retention, it tends to lead to weight gain. And then also we know that it's associated with folate deficiency and teratogenicity, and then also with the polycystic ovarian syndrome. So we often tend to avoid it, if possible, in girls of childbearing age. And that's probably the most significant or the most important caution to note about sodium valproate. But concerning psychosis, I don't know if there are other neurologists here with experience in that regard. I have not seen much of sodium valproate leading to psychosis.
Yes. Next question, which Stephen he asked about which of the anti-seizure medicines should be used in epilepsy and ADHD? What's your preferred medicines you use?
Okay, so again, it depends on where you are.
Yes.
And it depends on your availability, and also it depends on the seizure type. So for some seizure types, you will specifically go for specific anti-seizure medications, and you would try to avoid others. So I will not be able to say which one specifically should be used for which seizure and ADHD. But I can only say that if possible, you may have to avoid medications like phenobarbital in children with behavior problems, because it might lead to worsening of the behavior. But if you find yourself in a place where phenobarbital is the only medication to help in the management of the seizures, then I guess you probably have to use it. And then also try to use other medications like stimulants to help manage the ADHD.
Actually, the next question is near almost the same to some extent. He asked, how would you handle the child that visits with violent behavior few months after starting treatment with phenobarb? The seizures are well controlled if the patient had violent behavior in phenobarb. Actually, just a note about phenobarb. And pediatric technologies, although it's a remained cornerstone in infant, but after infancy we have to avoid as much as possible. What's your opinion?
Yeah, the same answer from me.
Yes.
If you have seen sudden deterioration of behavior after using phenobarbital, you may probably have to consider introducing a different anti-seizure medication and withdrawing the phenobarbital. Yeah.
If violent behavior occur and he is controlled on phenobarb, he wants not to be changed. Did you have any?
Yeah, so that is also very difficult, especially where the offending agent or the offending drug seem to have controlled the seizures. You need to have a good discussion with parents,
Yes.
and also the child involved.
Yes,
And,
I think it's tailored according to individualized according to the patient, according to the situation. We can't change or not.
yeah.
The same question from our mentor, Dr. Gab. He's asked about the affecting on cognition, about anti-seizure that affect cognition, because he said there's more like not only topiramate, the zonisamide, phenobarb, and also sodium valproate might affect cognition.
I
He wants.
agree perfectly. Yeah. So there are many other medications, not only topiramate, that will affect cognition. Some of the other medications do so as well.
And we have next question from Nathaniel from Ghana. He said, I'm anesthetic from Ghana. Can you please share some light on the consideration for an epileptic undergoing surgery in the perioperative period and intensive care?
Yeah, so the neurosurgeons, I don't know if there are any neurosurgeons here, they are super fan of phenytoin because it works a lot for them. We pediatricians and pediatric neurologists will not want to put our patients on phenytoin for the long term. But for the short term, that is during the perioperative period, if we want to avoid seizures, phenytoin is a very good drug, except that you wouldn't want to put a patient on long-term phenytoin, but it has always been super in the perioperative period.
Yes. Yeah. Next question also from Ayman, but I think it's not our scope for this night. But we have time if you can question. He said, my second question is, how often the EEG will be normal for patient with epilepsy? And which type will present with high rate of positive? So it's two parts. How often it's normal and which type is highly positive?
Okay, so my answer is that it varies from place to place and from practice to practice. First, it depends on what type of EEG you are doing. There are many types of EEG. Here in Ghana, because of resource constraints, we only do scalp EEG. We don't do intraoperative monitoring where you put the leads directly on the brain. We put the leads on the scalp. And we only do short EEGs for 30 minutes, maximum 45 minutes. We don't do long-term telemetry where you do prolonged EEG, sometimes up to 1 week with a video as well. So all these factors contribute to whether you have a normal EEG or not. So for us, the EEG is an effective tool in helping us classify the seizure type and also yes, to classify the seizure type and what to properly define the seizures, but not to pick up epileptiform discharges, because you may miss the epileptiform discharges doing just a scalp EEG for only 30 minutes. This is like taking a biopsy. You may go the wrong way and not pick the tissue with the pathology. So EEG for 30 minutes, you take a patient who is 12 years, all his 12 years, you are only taking 30 minutes of brain activity. And at that time, the brain may be behaving very well, and you may miss epileptiform discharges. So EEG, to answer your question, how often would the EEG be normal? It's difficult to answer. But in my EEG lab, for example, I would say maybe about 30 to 40% of the requests that come in, or of the EEGs that we do, end up with a normal results. And then you are also asking which type of seizures will present with high rates of positive EEG. So it's probably the same answer for the first question. It depends on how well the EEG is done and how long it is done, and sometimes even the the environment, and the expertise of the lab is also very, very important in filtering out artifacts and not reporting artifacts as abnormalities. These are all very, very important in interpreting the EEG.
Next question, but I think it's the question is said that what child with mild to moderate autistic spectrum disorder, ASD, do they need to be on any medication if they don't have a seizure and not very hyperactive either? I think you answered this question many times according to the patient, and must be tailored according to so let's go to next question from Candy Mary. He said, thank you for this informative presentation. My question is, there is a way of differentiate between migraine from epilepsy? If I heard you well, you said its manifestation may be similar to epilepsy. Yes, I think there is what's called migralepsia epilepsy. There is sometimes overlap between. You said that I think in your lecture, but there is sometimes confusion. What your opinion, Charles, somebody about the migraine and epilepsy? Sometimes difficult to differentiate between them.
Yes, so migraine, I mean, the most common presentation will be headache, and sometimes there is cyclical vomiting, and then sometimes there is cyclical vertigo. They may present with abdominal discomfort, and it is paroxysmal, just as epilepsy. The EEG probably might help if there is so much confusion about the diagnosis, even though there might be some similar presentation. A careful history and physical examination is always very important. Sometimes we don't get it right the first time, but we need to go back and do another, keep taking the history, And then in these days and age where every family has a digital a phone with a camera, if they can give you videos of the events, that also helps to improve the diagnostic yield, or to differentiate between these conditions. But most often, patients are very clear what they are presenting with. If it's headache, they will tell you it's headache. And migraine has some features that specifically makes you think that this is migraine. But again, they may coexist. So it's important to take histories over and over again and delve deep into the patient's histories to be able to say that the patient has migraine, the patient has epilepsy, or the patient has both migraine and epilepsy. A lot depends on history.
Next question, actually, it's not questions. He said in Italy, it's difficult to find a derm psychiatrist in our society also.
Yeah, so if it is difficult to find it in Italy, then you can imagine that it is very difficult to find them in Ghana. So we really struggle. There are many times we've had to take on the management of these patients on ourselves because we do not have the other specialists around.
The same or near. How do you screen language impairment in children? Is there any recommended tool? Thank you, great presentation. What's the screen language? In Iraq, we screen developed milestone, including language, and we assess, as I'm pediatric, me or our colleague, to assess those patients with speech or language impairment, particularly with epilepsy. Sometimes we send for specialists. Sometimes we assess by ourselves. What you are in your practice?
Yeah, so the same. We take comprehensive history at the first visit, and it often involves developmental history, delving into the patient's language development. And then, as I said, if you have any suspicion that the syndrome presenting may have a language deterioration component, then you may have to more frequently screen for language deterioration. But we use the same clinical tool like history to ask about language development.
Next question from Angela said, thank you for your nice presentation. I would like to know which antibiotic medication is more associated with weight gain?
Yeah, so I think I mentioned in the presentation or during the question time that valproate is one of the common medications associated with weight gain because it increases appetite. It also leads to fluid retention, and that is the reason they tend to put on a lot of weight. Yeah, but if you are using steroids also for the management of seizures, which we do in some seizures, then the steroids can also be the source of weight gain. Yeah.
Yes, the next question, depression management. I think it's when it's common with epilepsy, how to manage. I think you asked this many times. So the next question, he said, yesterday I came across a patient who has lost weight excessively. She is on sodium valproate and topiramate. Could this seizure be caused weight loss? I think it's sodium valproate. In contrast, his weight gain and increase appetite rather than decrease. But topiramate, the cause of her or his patient had been weight loss, I think, because of topiramate.
Topiramate, yes.
So,
you're very right. So
yes.
I've seen many patients with topiramate coming back with poor appetite. So that is one medication that may often lead to weight loss. Topiramate is
yes,
cause.
topiramate is yes. Garpella said, "Do you have any experience with suicide in treatment with levetiracetam?"
Yeah, so as I said,
yes.
I have not seen any children presenting with suicidal thoughts, but it is reported in the literature, especially in adolescents and older people. But in my practice, I have not seen any children. But we do have that caution where we often ask for that also, because it might happen when we do not know. Yeah.
It's more commonly cause ill or behavioral changes rather than suicide, but I think it's reported. Yes. Next question from Mariama said, "Thank you for an insightful presentation. Besides sodium valproate, what are other options in girl with childbearing age?" And in contrast, sodium valproate is avoided in childbearing age. I think might be there's written something wrong in writing. So what's your choice? Well, let's change the question to be more beneficial for audience. What the medicines antibiotics for childbearing, which would you prefer?
Yeah, so for children, for girls of childbearing age, we use levetiracetam, we use lamotrigine, and again, it all depends on the seizure type, because sodium valproate may not be effective for certain seizure types, but levetiracetam, lamotrigine are very good choices to avoid sodium valproate.
Yes.
In other regions with many options, they may have other options, but for us, it's levetiracetam or lamotrigine.
Yes. Regarding questions about absence seizure, about absence, I think it's not exact scope and absence according to the age, so we go to next question. Said from Nazmon, he said, "Thank you very much for very informative talk. Children with epilepsy and behavioral problem. Which better if you choose between levetiracetam and brivaracetam?" This is the new generation of levetiracetam. Brivaracetam.
So yeah, unfortunately, we do not have access to brivaracetam. So I don't have any experience with this. I do not have any experience with that. And probably I will talk of other medications if you want to avoid levetiracetam. Should be either topiramate or lamotrigine, because we do not have access to brivaracetam. I will not be able to speak to that. Yeah. I don't have any
question. I think you answered it, but because it's important, it's not mindful to repeat it. Which anti-seizure is the most safest for child with epilepsy that have developed recurrent migraine attacks? So epilepsy and migraine, which better for children?
Yes, so some anti-seizure medications have anti-migraine activity. Valproate does. In the past, even carbamazepine has been said to have some anti-migraine activity, but they may not be the optimal choices for migraine. So you may want to consider anti-migraine drugs. If your patient has both seizures and migraine, you might want to consider both anti-seizure medication and also anti-migraine medication. But valproate, for sure, does have some anti-migraine activity.
So next question from Zamir Fayaki. They said, can EEG help in ADHD and ASD? Is it useful?
So the EEG will not help to diagnose ASD or ADHD, but they are certainly useful because some of these children with ASD or ADHD may be having seizures that have not been picked up. So they may be useful in the evaluation of these children, but they do not help in making those diagnoses. There are screening and diagnostic tools for ASD and for ADHD that will be useful in making those diagnoses, but certainly the EEG may be helpful in ruling out some underlying seizure activity in some of these children.
Next question from Ayman. He said, patient with the seizure clinically diagnosed as epilepsy and his lab CT, MRI normal. That's because we are many patients with normal. As I think clinically we treat the patient, not treat CT or MRI. So to save time, we go ahead to next. Also from Ayman. Thank you for information of using steroid in the management of seizure. Which type of steroid and for how long? What's your experience with the steroid? Yes.
So the most common steroid we use is prednisolone, or in some places prednisone, and we use that for infantile spasms. Yes, for infantile spasms. And you don't want to use them for long period because the steroids themselves come with a whole loads of side effects. So we typically use them effectively for 2 weeks. But then because you cannot stop steroids abruptly, you'd want to taper them slowly over time. So we use them effectively for 2 weeks at high doses, and then we taper them over a period of about 4 weeks. So it becomes 6 weeks of treatment in total. In some other conditions where you think there is a immunologic undertone or autoimmune causes, some conditions, for example, with Landau-Kleffner syndrome, you might want to use steroids. We have done so with some successes in some patients. So these are some of the common conditions. Epileptic spasms, especially, is the one that we tend to use steroids. And that is because we also do not have access to the hormones that are used in developing countries, like the ACTH used in developing countries. So we tend to use steroids, and we also use vigabatrin. But that is also expensive for our patients because they will have to pay out of pocket. The steroids are very cheap. They are the cheapest you can find on the market, so that they are able to afford that. Yeah.
Question from Zaituni. It's important question, I think, for infant with on NT seizure medicines and a problem of insomnia. How can you overcome that insomnia in patient with epilepsy and receiving anti-seizure medicines?
Yes. So most of these anti-seizure medications disrupt sleep because they might cause drowsiness and sleep during the daytime, and then will disrupt nighttime sleep. So sometimes it's important to look at the dosing and the frequency of the anti-seizure medications. If you have a patient, for example, on a medication like the benzodiazepines, and they are going to sleep a lot, you may have to titrate and then be careful with, or you may have to titrate to get a good balance between sleep and seizure control. So, and also sometimes avoiding nighttime doses in some of these medications, or daytime doses, depending on where the patient is is sleeping a lot or where the patient is struggling to sleep. So modifying the doses and then also playing around with the timing of the medication are some of the ways to overcome some of these things. I don't know if there are any other neurologists here who may have an answer to that, but for now, that's what I will say.
This comment from Dr. Ghaib, he said, I think not only valproate increasing weight among anti-seizure, possibly pregabalin, gabapentin, and even carbamazepine.
Yeah.
So next, yes, question from Jacqueline. He said, at which point would you screen children with a sleep disorder for epilepsy, especially if there is no speech delay or regression? I think you answered this question according to assessment. Next question from Dr. Noor, neurophysiologist from Iraq. Is there any role of anti-seizure medicine in improving cognition and behavior in patients with ADHD with abnormal EEG, as example, Rolandic spike without clinical seizure? So any role of anti-seizure in improving cognition and behavior in patients with ADHD if you find abnormal EEG, particularly in Rolandic spike without clinical seizure?
Yeah, that is a very difficult question to answer. In my part of the world, we will not look for abnormalities in the EEG just because of other problems. But once you find it, then you have a reason to deal with it. So I have not encountered this situation before, but I suspect that if you have abnormal EEG and if they are consistent and the patient has cognitive problems, then you may have to think of subclinical seizures. Some patients, for example, with Landau-Kleffner syndrome, may be present with loss of language without any overt seizures. They may be having subclinical seizures, and they tend to improve when you treat with anti-seizure medication. So it's, again, there's no general answer to this question. It has to be individualized, and each patient will have to be evaluated on their own merits.
Okay. From Kazakhstan, Karko said, is there any work program for inclusive studying and suggestion for family member on how to interact and which country is best for avoiding comorbidities? He said about programs or any country had been developed well for psychocomorbidities. Do you have any idea about psychocomorbidities? Any study or some even if website or something like that to help the parent of the epileptic patient?
Yeah, I do not know about other countries as is being asked, but the general practice, which is what we also do here in Ghana, is as much as possible to encourage inclusive education, and where the children interact with other children in the same environment, and then at special times they are pulled out for special interventions. That is what we recommend. I do not know of what pertains in other countries, but I think that it cuts across. In many countries, the recommendation is to have inclusion as much as possible, except in severe instances where the child cannot cope in the mainstream curriculum, that you pull them out completely. Yeah.
Comment from Dr. Ghaib is that melatonin is widely used for insomnia. Yes, it's in our practice. Yes. It's used a lot. And
thank you very much.
Yes.
That is very true. We use melatonin also.
The Carcos also, thank you for very much. Hippocampal epilepsy with sclerosis of left hippocampal levodopa stem treatment used. Sclerosis of epileptic focus can affect laryngeal seizure numbers. Of course, the primary pathophysiology is very, very important in number and duration treatment. So I think you answered that many times. Thank you very much, Dr. Charles Hamoud. Your nice, fruitful, and excellent talk and discussion. Thank you very much. I hope to see you again, maybe face to face.
Thank you. Thank you very much, Dr. Karim.
Thank you very much. Now, just I have announcement about the global health. I might be there is this slide. The global health is the epilepsy project database provided a registry of existing epilepsy projects throughout Africa and Eastern Mediterranean, as well as in other regions. It identified information such as project location, institutional partners, project scope, funding sources, and voluntary need. The database is quick and easy to complete. By submitting information on your project, you inform understanding of efforts that are occurring throughout the world. To narrow the epilepsy treatment gap, the database will provide you an opportunity to learn from others and to explore collaboration opportunities that might strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas such as government, academic, and non-profit or philanthropy to learn about existing efforts, which offering a mean to engage on the next in this slide. This scan or the QR code to receive your certificate. Also, there is a link in chat box now to the certificate. Thank you very much for attend this webinar. Thank you very much, Dr. Charles Hamilton, for this informative. Thank you for ILAE for this opportunity to support this meeting. Thank you very much.